Welcome, everybody, to the Sapien podcast. Today, I've been very, very excited about this episode because we're going to be talking about mental health. We're going to be talking to a therapist I work with, Berenice Rosillo. She was once my patient, and now my colleague. We work together at Evolve Healthcare as part of our ketamine-assisted psychotherapy program. Berenice is one of the most special therapists I've ever met. She's so intuitive, she's so thoughtful, she's so sensitive, and we've had some really amazing outcomes with our patients, some of which we'll get into. I can't do justice to her credentials. She's an educator. She has her own private practice in Woodland Hills, California, where my practice is as well. And we've been collaborating for the last few years, and now specifically on ketamine. So Berenice, thank you so much for being here.
Hi, thank you for having me here.
Oh, thank you. So for the listeners that don't know you, and a lot of listeners don't know that much about therapists, maybe describe your credentials, your background a little bit so they know where you're coming from.
Right. So I'm a licensed marriage and family therapist. I'm licensed in California and Arizona. I also teach, and as you mentioned before, I teach at Pepperdine and UCLA, so family counseling and practicum. And I come at this from the side of humanistic psychology, so positive psychology, and like we've been talking about, mindfulness, more present tense psychology.
Present tense psychology. Mm-hmm. It's an interesting term. I know what it means. Mm-hmm. Maybe describe for listeners this approach, this humanistic approach, and maybe give them some reference what was before. You know what I mean?
Yeah. So before we used to have, which is psychodynamic therapy, and that's very related to Freud, which most of us are familiar with. And that was more like focusing on childhood-related trauma and how that has impacted the way you are today. So later on, a few decades later, we had Carl Rogers, and he is the father of humanistic psychology. And he comes at psychology looking at how human beings come with inner strength, and how our clients need unconditional positive regard and support, and that we look at strengths as opposed to deficits in our clients. And that would lead to positive psychology, which is what I believe so deeply in, which is that my clients already have a lot of strengths and positives, and it is my job to help them find them again, that they're already there. And this is literally what I tell my clients when I meet with them for the first time. We're going to look at things that work and make more of that, and look at things that don't work, and then we get rid of those.
Get rid of those.
Very easy.
It makes sense. It's simple. Mm-hmm. It makes me think about some of the principles of osteopathic medicine. I'm an osteopath, right? And I attribute a lot of my open-mindedness and my willingness to embrace different modalities because of those principles. And even when I went to medical school, I didn't necessarily think about it. I was just, I got into osteopathic school. It was a great fit for me. And all these years later, I realized how open. I was trained in Reiki. I got one session in Reiki. If you think about Western medicine training, that kind of forgets about spirituality, forgets about energy and this concept of energy, which we're going to get into today. I was trained in that. And that's so special. And it really made me think about sort of what else is out there, the strategies that you employ have been so effective over time. But when I met you, you're extremely open-minded. I think that's what connects us. And, for the listeners, one of the things I'm really trying to emphasize is just this idea that we don't know everything, right?
Right. Absolutely right. And that is one of the reasons why I really like working with you. Yeah.
And I like working with you because instead of both of us who are really trained in traditional Western medicine approaches, Western scientific thought, that's not the only thing we know how to do. We're willing to learn. So how is that? Because I find that most providers, whether they're therapists, doctors, nurses, whatever, we get so ingrained in our training. We're so sort of like dogmatic. Most people forget that there's a million other options. Why are you so open to it?
I believe that in treating the human, and I know you do as well, as a whole person, right? So we work with our clients and your patients in a way that we're looking at every part of themselves. And I think if we just focus on the one thing, like in my case, it would be the brain or the mind, right? But I also like to look at the soul. And I also like to look at the body. If someone is not sleeping, is not eating well, then they can come to therapy 5 days a week and we're not going to get anything done, right? So it's looking at it from like the whole person perspective. And I think that's what makes us more open-minded.
And that holistic approach, the mind-body-spirit connection, and the body's innate, the human's innate ability to come back to equilibrium and find a balance by manipulating the environment, the thought processes, the day-to-day habits. You can help someone's body and mind come to balance, come to its own homeostasis. Right. And this is a key principle of osteopathic medicine and something that really shouldn't be a part of osteopathic medicine. It should be the foundational theory upon which all medicine is practiced, because every year there's something new. Every decade there's a new school of thought. Right. But the more time passes, the more we realize that we have to work with what we have instead of always externalizing. And that's why I'm not a huge fan of aggressive pharmaceutical therapy. But I think there's a huge role for medicine in general, specifically psychedelics, but also cardiac meds and diabetes meds. I mean, there's a role for this stuff, but it cannot be the only option. You have an antidepressant and you have therapy and that's it. And if that doesn't work, sorry, everyone, we have nothing else. There's a million other modalities. So, you focused your career on this cognitive behavioral therapy, correct?
I do, yes. Yeah. And I do a lot of work with trauma and survivors of mass shooting events, which unfortunately has kept me very busy in the past few years. Survivors of crime as well and domestic violence.
And so is that work all also the CBT stuff, or do you bring in other modalities?
So I do a lot of trauma-focused CBT. So it's part of it as well, and solution-focused brief therapy. So one of the reasons that we were saying earlier that it's really hard for us to be more open-minded, and that leads to insurance and healthcare in general, right? We always get there, but we as therapists, as clinicians, we are supposed to provide work that is evidence-based. And in my world, we call it evidence-based practices. And if we do not offer those techniques or those theoretical approaches, then insurance will not cover treatment. So that really limits us, and we have to stay within those approaches in order for us to be reimbursed for treatment.
And here's the rub, everybody. When you have an open-minded therapist or a doctor like myself, everyone has to realize that the system is built with very rigid rules. And you may not like this, Berenice. I have a problem with evidence-based medicine because you do too.
I do as well, yes, absolutely.
So what's your problem with evidence-based medicine?
That it limits us. It limits me to see my client most likely as a problem, right? So like I said before, I come at therapy from like a strengths-based, and sometimes evidence-based practices would allow us or would actually limit us in seeing that part of our clients.
So it's really frustrating because there's a lot of scientific research out there. And in fact, there's research that goes back more than 100 years before sort of the established Western medicine. There was all sorts of, and there's research, more modern research that looks back on what happened over thousands of years. And what I always emphasize is this. The Western medicine system nitpicks the evidence that is beneficial for them, that is in line with their ideology, the sort of standard of care, if you will. And they establish that standard of care based on research, and then they're limited to that standard of care, and it's very, very hard to go past it. And if you as a provider or me go to a patient, we're like, well, for this patient, I think this other modality, let's say Reiki, because people know what Reiki is, energy healing, okay? It's non-touch based energy healing that it works for a lot of people, and it's been used for much, much longer than any of the medicines that we use in Western medicine exist. So whether you believe it or not, it's my feeling that, and there is research on Reiki. There is research on a lot of alternative medicine, especially for mental health, because it's such a huge challenge. And so my biggest problem is that even as evidence-based clinicians, it's not like we can use the full breadth of research, because you can't say, hey, I found this really great study looking at this product or this behavior, and I'm going to do this with my patient. No, if you document that, you're not going to get paid, which means you can't keep seeing the patient, which means you can't help them.
That is absolutely true. And that is one of my issues with it. So I understand research, and my brain is very research oriented. That's how I think, and that's how my brain likes it, right? So I do understand why we need research and why we need evidence-based practices. My issue with that is more limiting, and that it takes so long to get new theories or new practices that we can use to get to the point that they're actually evidence-based. And during that time, which could take decades, we're unable to use them, or if we use them, then we may not get paid and our client doesn't get the help that they need.
So let's not belabor it. The whole evidence-based model of procuring new treatments is broken because it's so slow and it's so cost prohibitive that anything that cannot be aggressively monetized is not going to get the high level research studies that, the general research community will embrace right away and start paying, the insurance companies will pay. Some modalities, even with an overwhelming amount of research, won't come through. Let's take psychedelic medicine, for example. I mean, it was working. They were using it. It was extremely powerful. It was one of the most powerful tools we had in mental health. And then with one fell swoop, they made all of these substances illegal in the 1970s. And that whole treatment modality is gone. Now we're back to square one in the 90s and the 2000s, where we're researching these products that were already being used and researched. And now it's like it's just starting over. And it's so frustrating because we have a serious mental health epidemic.
We absolutely do. And we need all the tools that we can get. But if we go back, and you and I, we've been talking about this and how insurance is not covering ketamine-assisted psychotherapy at this point, even though we have all the research, and we have more research that continues to come out showing the effectiveness of it, and we're still not being able to bill for it. Yeah.
We're going to pin that because I want people to hear the story about reimbursement for ketamine, because it's really, really, really frustrating what happened with Spravato. But before we go there, the mental health crisis, it is so bad. Before the pandemic, was seeing like 20-30% mental health issues in my primary care clinic, which I think is pretty standard. And when I say a lot of people have depression, anxiety, but when I'm actively managing those issues, like 20-30%, which I think is right on target of what most PCPs were doing. After the pandemic, it's more than half. Yeah. And the cases are far more severe.
Yes.
And it's not like they changed the reimbursement or the access or created any emphasis. And then, you mentioned mass shootings. This has been going on for decades. It's not like they've done any kind of, they'll create all of these safeguards in a school. They'll put all these expensive equipment in, but they won't invest in mental health. We talk about school shootings and we talk about gun control issues. We're not here to talk about that. But the elephant in the room is the mental health problem.
Absolutely.
We talk about homelessness on the streets. We've got Los Angeles is falling apart. San Francisco is gone. Other cities are following suit. And most of this is mental health, addiction, depression, schizophrenia, bipolar disorder, and zero resources. So, we're having this podcast and we're having this and me and Berenice connect because this is our mission. Our mission is to provide at least whatever we can pull from the ether, from the world, from the thousands of years, and now everything we have, we want to bring to our patients in whatever way we can. We try to make it as cost effective as we can.
Right.
And we do everything. And I just want everyone to know Berenice's private practice, my private practice, it's about access. It's about opportunity. It's not about mining people for every last dollar in their insurance. Right. But we also have to keep the lights on. So we can't divorce this conversation from reimbursement because most people can't pay out of pocket.
That is absolutely true. And you know, one of the main things that when we talk about reimbursement, so we know that in psychotherapy, the number one predictor of outcomes, successful outcomes in psychotherapy, is the therapeutic alliance, right? So
the connection between
the client and the therapist. That is the number one predictor. So, and that has been done through research throughout the years and decades. And it doesn't matter what approach you use. You could use CBT, DBT, TFCBT, I mean,
all the acronyms,
existential, all of them. You use any of them, and the one that we know that works time after time is the therapeutic alliance. So, and that is not part of evidence-based practices. That my clients can like me or not like me, and that doesn't get me reimbursed by insurance, right?
The human connection is probably the most critical part of healthcare. You know, especially obviously with mental health. And it's shown too with, you know, chronic disease management in the primary care setting, that close follow-up, frequent visits. This is how you really help someone. Again, we don't need evidence to understand. This is a foundational principle of being a human being.
Foundational principle. That is it. And the issue that we have, by the way, with mental health, at least one of, you know, the way that I look at it, I think is that disconnection. You know, human beings, and that you were mentioning the pandemic, so we became so disconnected from each other, and we know that there is this issue with disconnection that is leading to where we're at today. So there is a lot more depression, a lot more anxiety, but it's because it's related to human beings not being as connected as we used to be. We don't hang out with each other anymore. We don't spend time face to face with each other anymore.
Yeah, it doesn't count. And this is something I think it's talked about a lot and is obvious too. You're not going to replace the human connection, the energy I feel from you with a podcast or the telephone call or even a video conference. I want to ask you what you think about that. But my feeling is the further we get away from the physical connection, the more we rely on technology, the further we're getting away from real healing strategies. And that's not to say there's not a role for telemedicine visits. I'm curious what your experience is, because I've had this question a lot from patients, and I know people are going to be interested. Like, as a therapist, what do you compare the efficacy of having someone in front of you compared to doing these phone calls?
That is a great question. Great question. So my practice went from 90% in person and 10% telehealth before the pandemic to the other way now. So I'm probably 80% telehealth and 20% in person. And I think it all depends, right? Like, it all depends. Sometimes it works really well, and for some populations it works really well. The majority of my clients may be younger, so adults. I work mostly with adults, whether like very young adults to probably 60, 70, right? And for them, it works well. But if you have a 5-year-old or a 7-year-old, I don't think it works as well. I really don't. And I mean, other colleagues may disagree with me, but I think for therapy, because it's a specific type of environment, my clients are supposed to be in a private space, you know, probably their home, and they can be so open, and we're just talking. I don't necessarily need to be touching them, right? I don't necessarily need to do that. If I did, then I would be in office. And I think it's just as effective. And research is showing us that telehealth for mental health in these situations is just as effective. Now, if you have severe depression, severe anxiety, younger, so specific populations is just inappropriate.
It's inappropriate. So
ineffective.
It's not it's not a full solution. So yeah, absolutely part of it. And I do think that as the decades roll here, as we become less and less interactive in our normal lives, that the therapeutic setting should be a safe haven. It should be a place where we protect the interpersonal experience and we really encourage people to come in and see each other. Yeah. This is a loaded question. You're not going to like it. We talked about a lot of problems but why are we in this mental health debacle? Is it a lack of access to therapists? Is it a bad approach? I know what I think, but I'm curious your perspective. Is it bad medications and bad strategies? Is something entirely missing from the whole approach to mental health? What would you, if you had to pin it on something, or maybe a few things, what's wrong with our mental health system in America?
So not a lot of research, and yet a lot of research on this. And I think it all comes down to connection. I think we have become so disconnected. So think about it, Dr. Gary. So maybe 40 years ago, or maybe even in the way we grew up. I know the way I grew up.
80s, 90s.
Right. Well, more like, 80s probably for me, right? So I knew my neighbors. I would hang out with the kids. After school, I would come home and just you go outside and you hang out with your friends and you play games and do all of that outside. Nowadays, people are inside and with a screen. So there is you don't feel loved, you don't feel cared for. And don't get me into social media, which is like,
no, get into it. No, please. I mean,
we have 3 hours for today.
But it begs the question, like, is social media good or bad? Because it creates connection, but are they real connections? What do you think?
Yeah, no, we know, and this is not only what I think, I mean, obviously I believe in it, but we know, again, through studies that social media, especially for adolescents and even more so for female adolescents, that is causing a lot of depression and anxiety because of the comparison. They're looking at other people's curated lives, on that screen, and they feel like I don't do all those fun things, and they don't know that I know this as a therapist because my clients are telling me, I had the most horrible, incident that happened this weekend. And then the next session, we're talking about social media, and they're saying, oh, yeah, someone liked the picture that I posted 2 weeks ago. And I'm thinking to myself, that's when you were going through something so hard, yet your social media was showing something so beautiful. So it is, mind you, I'm not great on social media myself. I know the risks. I know that it serves a purpose. I'm not saying that we shouldn't have it, but I think that contributes a lot to the state of our mental health.
Yeah, yeah. And I don't think there's enough emphasis on actually educating people on what social media is.
Right.
Because it's not a replacement for a friend or a job
or a life.
Or a life. It's a tool. It's an interesting tool. It's an extremely powerful tool, and it's a tool that's extremely sort of monetized at this time.
It is.
So I think there needs to be education, and I talk about it in my clinic with my patients all the time, and especially the young women. Like, stop. Stop. Give yourself a mental break, even if it's for a day, a week, a month. It is toxic to your mind to see so much content. And the content is very, very manipulative.
Yeah, and it's so fast too, right? So we know that we learn better when we take a time to study, to think about what we're reading, right? So we read slow, we process, we imagine, that's our brain. But when you're going through social media and just like, swiping, and then the next one and the next one and the next one is nothing stays with you. And we know with studies of happiness, what is happiness? How do people get there? So one of the things that we know is comparisons don't work. They actually cause unhappiness. They do not promote the level of happiness that most of us or all of us are looking for. And that would be comparisons with people that are you perceive to be better than you or even lower than you. It's just that does not promote happiness. So
yeah, just feeling like you're better looking or doing better than someone doesn't make you happy. Absolutely. It's so sad because there's so many other opportunities. There's so much out there in this world, and it feels like it's going away. I grew up going to music concerts. All the bands. I love it. And I never really fully understood. And I realized that for me, that's my church. That's where I feel the love and the energy and the shared goal of a giant group of people. And I guess we worship this false idol, as they say, of these musicians or artists on stage, but it gives us something to connect about. It gives us a spiritual connection that cannot be measured. So the spiritual connection is really, I think, what everything is about, because it is missing in medicine. It is missing in therapy, I think. You tell me. But I think the spirituality, the energy, this discussion of energy is missing. Again, I got trained on a little bit of it in medical school, but it's not like I've ever answered a question about it on a board exam. I've never been, I've never talked to a colleague and say, that patient should really go and go have a group event, or, hey, maybe they should go to church or synagogue or whatever and reconnect with their faith. That sounds crazy to scientists because there's no evidence for faith. There's no evidence for this and that. And I'm like, well, with the end of faith, you have the end of spirituality. And if you don't replace religion with something of meaning, purpose, and guidance, you're left hollow. And I think that's what this social media problem is they're not real connections. If you look at another person in real life and you're like attracted to them, that doesn't forget sexually attractive, just like, hey, I like your vibe, right? Like I like your outfit and a thing. There's there's an energetic connection that's shared when you're looking at someone across from you and you're like, hey, great shoes or whatever, There's something special there that's completely lost when you click the like button. It's not there. It's this dopamine rush that the other person gets, but it's not, oh, wow, that person appreciates me. Hey, thanks for the love, man. Here's your love back. And you have this like exchange of energies. It's gone. And I don't know I don't think it was part of medicine ever, as far as I can tell, but it's gone from our normal day-to-day life. And I think that's part of the big problem we're seeing.
Right. I mean, spirituality has changed so much. So in psychotherapy, we do, or at least I do, trying to work with that whole person, right? Very holistic approach. I do look at my client's faith, right? And how that can help them, whether it's religious or spiritual. But the reality of it all is that that's not necessarily something that I want, that it would be part of my treatment plan, because I'm not for instance, a Christian counselor, right? I'm not trained that way, so I don't have that. But I do believe that faith, and also, studies showing us on happiness, right? That faith also plays an important role on achieving that happiness. It has changed throughout the years. People are becoming a little bit more spiritual. And again, we define spirituality in a very individual way. I think it's about connection with the self. That's a very existential approach, but that's how it makes sense in my head, right?
The existential approach is what's missing. I mean, whatever you want to define spirituality, we don't have a machine to measure it. We don't have some calculation from some questionnaire, but it's real. Energy that people share has been described by religion, by healers, by shamans, by cultures over thousands of years, and it's not discussed or explained. And just because you can't measure it doesn't mean it's not real. Just because I don't have a double-blind placebo control study for it doesn't mean it's not real. You can't monetize faith unless you're an organized religion. This is a different conversation. But my point is that when it relates to medicine and healing in the Western medicine world, it's very hard to monetize belief and faith. So I feel like that's part of it. If someone could, it would be. I don't know. I'm obviously very jaded about the Western medicine system and how manipulated it is by financial gain.
And interesting, but coming from a doctor.
I think most of my colleagues agree. They're just not, I'm vocal about it, and I'm trying to trying to meander my way through it and find pathways. It's just hard.
It is.
So the mental health system is a problem. But we are upon a revolution of psychedelic medicine. And psychedelic medicine is not just taking psychedelic drugs. Psychedelic medicine is essentially therapy with an adjuvant of a substance that helps lubricate, expedite, intensify the therapy. It is anchored in traditional shamanistic and religious behaviors, because psychedelic ceremonial experiences have been a part of human history for thousands and thousands of years, and was a part of Western medicine until the 1970s. Let us not forget. So when we talk about psychedelic medicine, one, we're talking about a very ancient tradition. Two, a not so ancient evidence-based modality that was destroyed by political pressure. And now, as we find ourselves completely at a loss, we have had decades of antidepressants, SSRIs, SNRIs, and the like that are ineffective. In fact, most of them are no better than placebo in the research studies that they use to promote the drug. You and me talk about it all the time. So I introduced you to psychedelic medicine.
You absolutely did.
What are your thoughts? I know it's a general question, but what are your, what have you taken from this? You've been in it for just over, I think, a year or so. We've been doing this 2 years?
Almost 2 years, I think 2.
It's been a while. It's been a while. As a traditional Western medicine clinician, what is your big takeaways, or, just tell, or maybe not even as a therapist, as just like a human finding out about this later in your career?
Absolutely later in my career, and absolutely where I had no idea. I'm being very honest here. I didn't even know ketamine was a psychedelic or was in the family of psychedelics. You are the first person that ever said that to me. And I remember when we talked about it, and I went home and I'm like, what is this? It just sounds weird. I have to look it up. And then my brain got into research on it. And I was like, wait, this sounds good.
Overwhelming research, right?
Yes, and that's exactly it. And I did not want it. I'm very skeptical. Again, my brain is very scientific, and I thought this sounds a little, it's maybe just this website, this site, right? So then I go into UCLA studies, and then I'm like, oh, this is interesting. And then I go into Harvard studies, and then all kinds, and I keep reading, and I'm like, oh, interesting. So when you and I met the second time, at that time, I already knew that I wanted to be involved in some way. But one of the main takeaways that I have so far in our work with ketamine-assisted psychotherapy, and I must say ketamine-assisted psychotherapy, not just the ketamine for me, right? Not just getting the psychedelic, but actually the psychotherapy component of it, to me is, obviously for me, is the most important part. But
it is.
I look at it as, I see, and this is what I have seen with our patients, right? That something that would take me maybe, 4-6 months in talk therapy, weekly sessions, we see that in 6 weeks, in 6 sessions with ketamine-assisted psychotherapy. And there is no denying that. We see it. We see it even in the way that, and I always tell this story when, our patients ask me, how is it, how do you know it works, or what can you tell me about it? And I always say, we had one of our patients, which we did, that walked into my office the first time and walked in, I don't want to say more, for confidentiality, but that walked into my office the first time. And this patient was looking down and looked like probably 3 inches shorter than they are. And just very defeated, even in the way they walked. And to be fair, I actually thought they were probably 10 years older than they actually are. When I saw the file, I thought I had seen the wrong file because of the age. And then we started working together. We had, with this patient, I believe we did a little bit more sessions. And at the end, this patient comes in dressed very summerly and looking tall and just smiling. And it's like, okay, so these are my goals, and I already did this and that, and all of that related to the goals that we had set up for treatment. So that's how I know that I really like this new wave. And I do believe this is a new way of psychotherapy. It's psychedelic.
It's interesting.
We both saw it.
Because you see it with a patient and you're like, wow, that's special. And then you start a new patient and you're like, oh, how's this going to go? And then 6 or 7 weeks later and you're like, oh, wow. And so, okay, we've done a bunch of cases now. It makes me mad. I'm going to do a little rant. I am mad that this modality that is overwhelmingly safe, ketamine is one of the most used drugs in the world. It is used in pediatrics when they have an injury in the emergency room because it's so safe. You can give it to a kiddo and then they come right back and they don't have toxic effects like opiates and benzos and stuff. This substance that has overwhelming evidence from the 1950s, 60s, 70s, no, not 70s, 1950s, 60s, then 90s, then 2000s. It was reborn and more research. Okay, so we have all this research for ketamine, and it helps with all of these really, really common overwhelming problems, depression, anxiety, addiction, right? Yeah. Still not approved.
Well, I mean, ketamine is in California, so that's another thing, right? Do we get into states and federal government? But ketamine is approved in California, which is the only one I work with because
approved for, but it's not paid for by insurances for assisted psychotherapy.
No, it's paid as it's a whole.
The psychotherapy is paid.
But we go back to the limits, right? It's very restricted because it would only pay for the 45-minute session or the 60-minute session, but it doesn't pay for what we need. And what we need is at least 2 hours, right? And insurance will not cover that. Some people say they will, but you have to do like billing gymnastics to be able to.
And also, if I'm as the physician going to be administering ketamine and you as the therapist are going to be giving it, I mean, there are no reimbursements for the physician reimbursing it. That would be cash. So it's completely connected. So let me break something down for everyone. Berenice, as a therapist, can bill for the therapy when ketamine is delivered. But I, as a provider, cannot bill or use their ketamine on label because doesn't have any indications. So I have to use it off label. I can't get paid for it. And let me tell you the other part of it. Ketamine is so overwhelmingly evidence-based that recently, a few years ago, Johnson & Johnson released Spravato. Spravato, the actual drug is called S-ketamine. S-ketamine is the S enantiomer, which is a mirror image. Enantiomers are mirror images of molecules. Essentially, the two mirror images have a very, very, very similar, if not the exact same result on the body, right? Sometimes there's differences, but minor. So Johnson & Johnson used a technique to separate the S enantiomer, went to the FDA with only 2 short-term studies. I believe they were less than 12 weeks, and rapidly got it approved for refractory depression. Interesting. So the S enantiomer is FDA approved for depression, but the original drug is not. Why is that? Well, ketamine is a generic drug that was invented in the 1950s or discovered or like they broke down a bunch of particles and were able to extract this drug. We're not going to get into all the details about that, but basically they've approved the one that's owned by the drug company, but will not approve the one that's generic and overwhelmingly used in the world. Secondly, they do not approve psychotherapy. So when I bill for Spravato, it's a very similar protocol that we use, the 6-session approach. They kind of do 2 times a week. They won't pay for therapy. They give them the drug as an intranasal spray, and they sit in an empty psychiatrist room for 2 hours, dilly-dallying, playing on their phone, whatever, missing the point entirely of what we're talking about. If you've been listening for the last 20 minutes, that's irrelevant. Even if there's a small benefit, we're not in the business of just giving drugs, crossing our fingers. We already proved that doesn't work. Right. So on one end, they approve therapy, but they won't approve the drug. On the other end, they approve the drug, but not therapy. And maybe some smart clinicians out there, if you're listening, have figured out how to manipulate it into a reimbursable scheme. But let me tell you guys, I spend all my time running my business. I have not figured out an effective way. And I'm sorry, spending 20 hours to get everyone to approve everything is not viable on scale to help populations. So essentially what they've done is nothing. They proved, I hope this proves to everyone, they proved that ketamine is effective.
It is. Yeah.
They proved that ketamine is safe. And they suggest that the therapy is essential, but they didn't put it all together.
Right.
So what are we doing here? Well, what me and Bernice are doing with our colleague, Yuni Fitucci, who helps me run the the practice and my lovely team at Evolve Healthcare, we're working to bring the cost down as much as we can.
Yes.
But we will not be infusing people high doses of ketamine while they're asleep and telling them it's going to help. I will not be administering ketamine and putting them in a quiet room and telling them to cross their fingers. I will only offer ketamine-assisted psychotherapy, or another, once available, hopefully we can get psilocybin and we can get MDMA. There's other substances. I know people listening, there's other substances. Those are the three. Those are the three that have a pipeline. Those are the three that have tons of evidence. And those are the three we're going to focus on in this podcast, because yes, there's ibogaine and ayahuasca and mescaline, and we can keep going, San Pedro, whatever. I love it all. Maybe we'll get into it. But as clinicians, we need to start where we can start.
Exactly.
And this is where we're starting.
And also to add to that, not only the issue with reimbursement, but also insurance. If you remember when we started working together, I had a professional liability insurance that did not cover ketamine-assisted psychotherapy. And out of all the ones that I was researching, I could only find one. And I obviously am with them now, but there's only one professional liability insurance company that covers this. And that is changing, I hope, because there is so much research that's coming out. And I mentioned before that to you that I'm part of the ethics committee for CAMFT, which is the California Professional Association for Marriage and Family Therapists. And in our work, we had a subcommittee, which I was part of, that did a lot of work on the ethics of ketamine-assisted psychotherapy. And we're able to come up with a lot of information that is coming out now to MFTs in California. And once that happens, then I feel like my colleagues would feel a little bit more secure in working with ketamine-assisted psychotherapy, which hopefully that would lead more professional liability insurances to cover that, because it's hard. This is not... I'm trained in EMDR. So if I want to do EMDR...
What's EMDR for those listening?
Movement desensitization and reprocessing. So this is the therapeutic approach that has become very in nowadays after Prince Harry, talked about. EMDR is used mostly for trauma, to process trauma and memories that are so deeply rooted in the subconscious, unconscious part of the brain, of the mind, that we need to desensitize and bring forward, desensitize and put back in a way that our clients are not as sensitive to triggers, to activations of trauma. And but for that, EMDR is evidence-based. So I don't need any extra training. I don't need any other professional liability insurance. I mean, I got my training, right? But after that, I don't need any more. I can be reimbursed. And actually, some insurance networks prefer that. So when I'm going through credentialing for insurance networks, I always mention, I'm EMDR trained. So CAP, so ketamine-assisted psychotherapy, is difficult. If you want to become a therapist that works with CAP, there is some things that you need to do extra to be able to do that. And I don't mean just training absolutely, but more than that.
So lots of obstacles to barriers to entry.
Yes.
So there's barriers to entry for the physician. Mm-hmm. There's barriers to entry for the therapist. Mm-hmm. There's barriers to entry for the patient. Right. You still have a lot of misinformation about psychedelics being somehow dangerous, which as a class of drugs are not. And even when you look at studies of drugs of abuse, these are the bottom of the barrel. Mm-hmm. Where, opiates, alcohol, cocaine, these are the things that are killing people and are dangerous. And and when you look at even things like MDMA, very, very overall safety profile. And we need more tools.
Yes.
They're not giving us access to tools. Mm-hmm. So we have to go to war to get the therapies and the modalities we need for our patients.
Right.
And we're willing to do that. But I would just hope that with this revolution, with the decriminalization of psychedelics, more people will listen to podcasts like this and listen to therapists like yourself. Again, I'll say this: Berenice has never done a psychedelic. She's unbiased. People argued about psychedelics all the time. Like, hey, well, when you were young, you did them, so you're biased. And there's been researchers, some really amazing researchers that are like, hey, I'm going to go into this space because I've never done it and I want to give it a fresh approach. Michael Pollan, famously wrote this book and he had never done it, and he shared all of his experiences. He's not a researcher, but he's a journalist, and he wrote this amazing book, How to Change Your Mind. If you haven't read it, read it, or watch the show on Netflix, whatever. Go ahead.
One thing that I do want to, and this is obviously part of the psychotherapy, part of it. So full disclaimer, I'm going to talk about it in a good way for us. But so something that I'm asked when I'm talking to my colleagues or clients or friends, out there in the community about ketamine-assisted psychotherapy. So they say, well, so isn't it the same like taking ketamine, special K, right? Like as an underground drug and psychedelic. So what is the difference between that and actually doing ketamine-assisted psychotherapy, right? And the difference is the psychotherapy. So people go and use the drugs like off the street or, in a rave or like a fun environment, and there is no change in their mental health, right? Because they're doing it for fun, and that's it. But when they do it as part of a treatment protocol in the way that we do it, which is again the psychotherapy coming in, then we use a neuroplasticity window, which is what ketamine does, right? Like it creates that neuroplasticity that then the therapist and the client working together, they come in and they use that neuroplasticity window to create new patterns of behavior, of thought, of thinking, obviously, right? That would help
behaviors.
Thank you. That would help them move forward in life and then achieve those treatment goals that we want. So it is completely different, and that's another issue that when we talk about ketamine. So the difference between going to a ketamine clinic or like doing ketamine-assisted psychotherapy. You need a treatment protocol. Otherwise, then it's just something that you do in the moment, and it could be fun. It could be you take a great nap.
Or it could be really dangerous, too.
Or it could be, thank you. Yes.
Very dangerous. So ketamine has addiction potential. There's no doubt. Ketamine can be adulterated with other scary products like fentanyl. There's no doubt. So we're talking about this recreational use. We're talking about ketamine clinics just giving the drug without therapy. And what we're trying to emphasize here is this combination. And one of the things I'll even add to that is we're trying to almost recreate the ceremonial experiences that we've read about and that have been part of human history, right? We create an environment that's really special. Our therapy never starts with drug. We start with therapy only, intention setting, goal-oriented discussions, focused on what a patient wants to achieve. We do therapy throughout the drug sessions, and then we do something called integration. Integration is where the money is made, right? That's where all the pieces come together to really make a difference. The set and setting is critical. When you're at a party with some random people, when you don't have access to good temperature, adequate hydration, maybe there's someone really hostile to you, or it's just not a safe environment. This is how you have what is called a bad trip, and where psychedelics are completely ineffective. All of that is important. And then dosing, right? We spend so much time in our clinic thinking about the dose. There's so much evidence looking at what doses work. The dose is critical. Ketamine specifically, more so than the other psychedelics, has a dose-respondent reaction curve, meaning the different doses actually produce different results.
Right.
And we see that in clinic. That's why you can give a mega dose and someone goes and has anesthesia. They don't feel anything. They don't remember anything. You can do surgery on them. They come back. That's not what we're doing.
Not at all.
We're giving baby doses compared to that, much smaller doses, and very thoughtfully and preparing our patients and guiding them through the experience. It's so important. All of these things are so important to dispel what we were just talking about, these bad ideas, this misinformation, the fear, the inappropriate fear-mongering about its dangers. That's all made up stuff. It's not that it's not true, but the fear-mongering about it is made up, because when you do any substance, like Tylenol, if you just take a bottle of Tylenol, you die from liver failure. Done. But you still have that in your medicine cabinet, and we trust that you only take 2 or 3 or whatever. So there's a huge disconnect between the psychedelic medicine space and the traditional medicine space when there isn't. It is a made-up, fabricated separation that does not have to exist. And we hope to convince some people that that is the truth. And
it matters how we do it, because I would not feel comfortable as a psychotherapist doing it on my own, by myself. So we talk about clients, microdosing or doing ketamine on their own and then coming to session. And that doesn't work for me. The way that it works for me is actually, and we do it like in your office, right? Because we have our patients get their vitals, measured before. We do the set and setting. I do mindfulness with them, meditation before, to make sure that they're relaxed enough and they never fall asleep.
Not with the doses we use.
Exactly. We want them to be present, to be able to take advantage of the benefit.
So you mentioned the benefits of ketamine. There's a couple. So I want to get into, there's two. You already mentioned the neuroplasticity that it creates, and there's a bunch of bench research in animal models, obviously, looking at its ability, animal models, and also just like petri dishes, looking at the ketamine's ability to increase the dendrites and connections of neurons, and they work differently, and it's this amazing process. We love it. There's something else though. When the patient is under the experience, once you give them the medication, they go into a different state of consciousness. So a lot of people will say, oh, they're altered. I don't want to call it altered. I want to introduce this concept of a holotropic state of consciousness. Mm-hmm. And this is a concept I'm introducing to you, and this is something me and Berenice are just really starting to talk about as I dig deeper. What is your observation when someone has 30, 40, 50 milligrams of ketamine? What is the effect on their consciousness as a clinician for you?
Well, they do go into this different state of consciousness. They know where they are because they're able to communicate with me if needed. And I think is worth mentioning that I'm with the patient the whole time. I do not leave the room, almost never, unless,
we're in session 4 or 5, right. Or they're in session 4 or 5, and the patient's like, "Hey, give me 20 minutes. I kind of want some privacy." That can happen.
But when they're going through the experience, I'm always there with them, and they know they can tell me if they feel hot, if they feel cold, if they feel like they want to talk to me about, So they're not gone. There is a different state. They know who they are and they know where they're at, and that matters for safety, right? Like just for safety reasons for our patients. But to me, that is the different state that they achieve, but still remaining, knowing
they're not drunk.
Right.
They're not drunk and behaving. So this is what I want to get into. Holotropic state of consciousness is a term popularized by Stanislav Grof. Okay, and I'm going to go ahead and introduce this book to people. I think it's one of the most profound books I've read in a very long time. I'm not even done with it. There's a second volume. Yeah.
You've been telling me for a while about
when I find something that transforms how I think, I share it with everyone. Mm-hmm. And I also don't just read it all and say, got it. I'll read it, and then I'll read it again. And then I'll read the chapter that I was really excited about before moving forward, because if you don't integrate it into your mind and it doesn't become part of your thinking, then it's not going to be. So, The Way of the Psychonaut by Stanislav Grof. Stanislav is a Czechoslovakian scientist, MD, PhD, who started his work with LSD specifically in the 1950s, late 1950s in the Soviet Union. Soon after Hoffman discovered LSD, he sent it around the world to different researchers, and Stanislav was able to have an experience as part of the research in the late 1950s on LSD, and had a transformative experience and realized that there's just so much more to consciousness and to the theory of how we should work with the mind. And he coined this term holotropic state of consciousness because he wanted to make a distinction between taking a substance or doing a behavior that makes you sort of confused, bewildered, not yourself, and other substances and experiences that connect you more to this energetic field. It connects you, holotropic means it connects you to the whole. And it comes from the word heliotropism, which is when a plant grows towards the sun. And I love that because we're just trying to get closer to that
big picture that we're missing, this thing that we don't, Western medicine can't describe it. We can't measure it with the tool, but we feel it. It's there. Some people feel it more than others. It's described as Buddha. It's described as God. It's described as vibes. Huh?
As nirvana.
Nirvana.
Right.
There's so many words. There's so many stories. There's just thousands and thousands of examples. And yet,
Traditional psychiatry, traditional psychology, the foundational principle is that consciousness is generated in the brain. That we are this amazing, complicated machine, and that the nerve signals and the neurochemicals in our brain are so complicated, which we don't understand, and they create this consciousness, this sense of being a person or a dog. I don't know. I think dogs have, a lot of things have consciousness, and that's a whole deeper conversation. Maybe this table has consciousness. We don't, that's for a different discussion.
That's philosophy too.
That's but that's the thing is, a body, a human mind, body, spirit connection is about philosophy. It's about physiology. It's about religion. It's about everything that's happening in our world today. It's about social media. It's all connected. So you can't just be like, oh, I can measure the nerve impulses. I can measure the serotonin, even though they can't. And the serotonin hypothesis is now debunked.
It has been.
Completely debunked. Yes. So remember, everyone, that traditional psychiatry says that you had a neurochemical disorder in your brain. That is now debunked. And what had changed after that was debunked? Nothing. I'm still told to prescribe antidepressants to people that are depressed. Told by insurance companies and health systems. That's how doctors operate, right? Holotropic state of consciousness is something I wish everyone understood, because it's not just drug induced. It's a sense, a connection to the energy flow in the universe. And when you think about consciousness, why it's so critical is because a lot of people listening to this, and a lot of people in general, don't believe in energy, or they think it's like fun words, or they think it's hippie, jippy, dippy, whatever, right? But it's not, because we have never, ever, and we've tried, been identify the physical matter-based source of consciousness. We have no idea where our consciousness comes from. We have no idea how to measure consciousness across different creatures and different brain structures. We don't know where it comes from. And yet our entire treatment is grounded on that foundation, that I'm going to mess with the chemicals in your brain, and I'm going to talk to you, to your brain, and give you positive thoughts. And that's how, but they don't acknowledge the energetic component.
Well, I think too, and this is where you and I differ a little bit, right? Like for me, again, being very scientific minded, I know I may not be very much in my work, at least, into energy and energy patterns. But something that I do know is that there are things that I don't know. And that I am very, and also when you think about quantum mechanics, right? That is part of exactly what we're talking about here. I just don't know enough. My brain doesn't have that knowledge.
You're going to read The Way of the Psychonaut, and you're going to come back in a month or two, and you're going to be blown away, because thinking about energetic energies and energetic fields is the only way you can actually take the theories of quantum mechanics and meld them with the theories of Western medicine and science. It's actually, none of it makes sense unless you separate yourself from the concept that we're just a sack of neurons and chemicals, and that everything is internal to us. It doesn't actually make any sense. No. And I'll give you one better, you guys. And this is, I have never said this to you, Berenice. You don't need to believe in it, because you're a real person. You're a true healer. And when you sit in the room with someone, all you're doing is emitting the energy, feeling their energy, and using your intellect and your training to guide your traditional therapy. But I've watched you do it. It is driven by energy. It is driven by this feeling. Yes. It is driven by the connection that you have to the person. And we don't need any evidence to know, because you can see it when you're working with them. And the patients come back to me and they're like, why is she so different? Why did I have this experience? And I want to explain to them that even though she doesn't really believe it. But I'll get to her. I'll get to you about it.
You know what? I think it may be also vocabulary, right? Because what you're saying, I absolutely believe in that. I was saying before that is the therapeutic alliance, right? So I believe in the connection of the therapist and the client. So when I'm there with one of my clients, I always tell them that nothing else matters in the world to me. So for those 50 minutes, an hour, 2 hours, you are it for me. You're the most important part of my world. In this moment, I'm not thinking about my house. My house could be on fire, and I'm not thinking about that. I'm thinking of you are my most important being in this moment when I'm with them. So to me, I call it connection. I call it understanding. I call it, I guess the best way to say it is connection and also care. I have unconditional positive regard for my clients. That's part of who I am as a therapist. I'm a humanist. So that's part of who I am. So for you, that translates, or the vocabulary that you use is energy. And for me, I think we're talking about the same thing. I just call it something different. I call it connection.
And for the record, I'm a baby in this space. I am just starting to use the word energy. I am just starting to meld my traditional approach with my alternative approach, and with what is an entire field of study is energetic healing, the kind of bridge between traditional religion and spirituality, right. These shamanistic ceremonial experiences. And then you get into these other behaviors, which I already did, which is kind of how I came to this, is I always did deep breathing. Deep breathing was the most obvious thing to me. When I was stressed out and I discovered the Wim Hof method, it was the most obvious thing. And when I would do it, I would feel the same kind of feelings that I would feel when I was at a concert with a bunch of people, or if I took a substance that made me feel more love or more nature, and I never had a word to describe it. I knew there was energetic levels. I knew there was something deeper than what I was feeling. I pursued religion aggressively, looking for that explanation. And, in the early 2000s when I was in college, it was like The End of Faith by Sam Harris and Hutchinson and all these people like really making religion this negative thing. And I totally bought into that. And I've completely done a 180 because I'm like, there's just more to this world that we cannot explain. And just because organized religion has done some bad things in this world does not mean that it has no role, or that it needs to die, or that it's somehow inherently evil, not true, and silly to think about, because it's done so many beautiful, amazing things. So when I learned this term holotropic state of consciousness, what I realized is we use in America drugs that reinforce the ego. Caffeine, nicotine, cocaine, alcohol, stimulants, Adderall, Vyvanse, extremely popular, right? They all give you a sense of ego. They make you fired up and aggressive, and sort of like your inhibitions drop and you become like this kind of primitive, aggressive, primal, maybe not primitive, but primal version of yourself. But it's not like, you never feel good.
It's false.
Because ego is false.
Mm-hmm. Yes.
Because ego is just a part of you, and maybe this is where Freud, by the way, had a lot of really fascinating things that tie directly into what we're doing. It's just not like our foundation anymore.
Because we know a lot of that was debunked. I mean, we're grateful that he, is the father of modern, quote unquote, modern psychotherapy, but we do.
There was limitations to his work. And if anyone gets to reading The Way of the Psychonaut, and we will review it for you once me and Berenice complete this, he actually goes deeper, and he says while Freud was maybe not 100% right, he gave us an amazing model to look at it, and he goes further. He got us thinking about, and then he goes further back into the womb, which I actually think is where it starts making sense to me, because there's no way you come out of tabula rasa, of blank slate. You just don't. There's other things. You're affected by things that are happening in utero from conception. I know even like vitamin D affects baby's development with vitamin D status. There's so much to it. So we can get into that later once we went. But more importantly, it's these states of consciousness that let us connect to the whole that are the healing modality. And as I was saying, like I use deep breathing. I used cold immersion therapy. I went to these communal environments, and I was all going closer and closer and closer and closer. I think that is that connection that we're talking about, that interpersonal spiritual thing that we keep trying to kind of talk about in this podcast. I think that is accomplished by a striving for, because you can never stay. A holotropic state is a transient state. If you were in this further connected state to the universe all the time, well, then you wouldn't notice the bus driving at you and hit you. So our brains, or the lion, the common is the bear attacking you,
It's just not possible.
Well, you can't survive. So our brains are these amazing machines that interpret so much information, and they take in the visual, the energetic, the auditory, all this information. And what it actually does, what the brain actually does, is filter. It dumps information out, and it creates a world that you can survive in.
Right.
You can predict what's going to happen. Hey, that lion's going to come after me. I'm going to walk that way, right?
Exactly.
But if I'm connected to the entire energetic sphere of this world, well, I'm not going to notice the lion, and the lion's going to eat me, and it's going to be...
you're gone.
So we are evolved to not live in a holotropic state, but we also have had all of these modalities to connect to it. I believe that all of these psychedelic drugs, they dissolve the ego.
Okay.
They break down the ego. They break down the sense of self. And with the dissolution of the sense of self, you are able to access the energy that's already there inside of yourself and outside of yourself.
Okay.
The ego is part of this mechanism that our brains use to protect, to survive, to thrive. But if it's too overly emphasized, because all you care about is how you look from that picture, that hitting that like button, and that's the only thing that hits you, you're hollow. You never actually realize that it's deeper than that. That if you want to like that person for how they look, maybe like go give them a high five or give them a hug, or like at the very least like a message with words, because words are powerful. So I'm just saying, like, the energy part can be accessed through holotropic states. Now, ketamine, that experience that you're having in the office, I believe, is someone dropping their ego, disassociating, and being channeled in. And by you being present to guide them towards positive thinking, which is why I think CBT is a great adjuvant for ketamine, because it puts you into a holotropic state. And then you as a guide them towards a better outcome.
It's solution focused, right? Like, what would work better? I completely agree with you, by the way. I do think that is the difference, because we can look at why does a psychedelic work, right? Like, why does it do what we're saying that it does? And obviously medically there is something to it, but also I do agree that there is this sense of self that gets disrupted. That's how I think about it, right? Especially with clients that we have worked with in ketamine-assisted psychotherapy that I was working with before, right? Like that I've been working with for a while. So that sense of self was so ingrained, and this is who I am, and who I am is an anxious person or a depressed person or someone that has gone through a lot of trauma, and this is who I am. But then when we come to this in as you mentioned, a holotropic state, then what we're trying to do is to dissolve that sense of self so that we can input, I guess, more a more driven, more compassionate, more connected, and more highly functioning person, instead of that traumatized or anxious or depressed person. So I completely agree with you. I think that what it does is it dissolves the sense of self that you were carrying, and then that allows, as the providers, the opportunity to maybe inject a different one, and probably that's not the right terminology, but to implement
or guide, maybe guide is the best word. It's like, hey, like, here's a different way you can think about this.
That's exactly what, and it's so simple, but it is so complicated, right? It's very complex, but it's so simple. This is a different way of thinking about this, or a different way of going about this, or you can be this person. You don't have to be that person. But before, it was just like talking through it, which is harder. It takes longer. It's absolutely doable. It just takes a little longer,
which some people don't have. Like, people are suffering, So this whole question of like, I'm going to do 6 months of therapy, if you can afford it, if you can keep your life stable enough, show up every Thursday. It's hard. We need real modalities. We need things to help and save lives. There's a term in traditional psychology for people that can sense energy. It's called emotional intelligence, EQ.
I thought you were coming up with a whole different thing.
No, they don't describe it that way. They don't describe it that way. And when we answer questions about it or people talk about it, it's like this kind of like, again, they kind of foo-foo it up, but they know what they're talking about. People that can feel other people.
Yeah.
So how do you measure emotional intelligence? Where is that coming from? What is it that we're noticing about people? I'm saying it's the energetic field. It's being open. It's having your heart chakra open to the energy, being able to understand what it is, and then being able to act on it, right? So most people, I think people in general feel it all. They don't have the tools to understand what it is and then to act.
Connect with it, right? Because I supervise practicum students, clinicians in training, right? And one of the things that they always find fascinating, although it seems odd to them, is that when you see a client walk into the door, into your office, the moment that I see my client, I know if they had a good weekend and if they didn't. And they haven't said one thing to me, and this is not body language.
Right.
By the way.
It's not body
language.
language.
It's not. No.
Please, anyone who thinks that it's because their head is down.
Body language right now, right? So it is not that. I know them so well that we have reached a level of understanding of each other that when I see, and me as a trained clinician, right, when I see my client walk in that door or even show up on the screen, I know exactly, and I'm like, okay, so what's going on? I know that something is happening. And there is, again, this is just a different kind of understanding, and I go back to a different kind of connection.
And one that we don't have words for, even though they exist. We don't have a machine to measure. Maybe someone does, and or maybe yet. Well, I don't know. But it's definitely real. It's part of the teachings of every major religion. This is where the religions agree, right? What we're actually talking about is where all the religions come together and agree. Now, whether you take this energetic field and anthropomorphize it as some being,
right?
God, Jesus, Moses, whatever.
Higher power.
You can say Mother Earth. I used to say Mother Earth, Mother Nature. There's a specific religion that believes it's aliens, actually.
Right.
But that's the same thing, you guys. You got to understand that if they think that your energy is coming from aliens, well, we don't know. We don't know where this energy is coming from. We can't measure it. So they're all just ideas to describe where our consciousness comes from, where this energetic field that we all feel that affects all of us. Then you get into the subatomic level, and we're talking about vibrations, and everything exists in these vibrations, and how do these vibrations play off of each other. And it just, as you start thinking about a lot of the stuff that I considered foo-foo, everything from craniosacral therapy, which is a modality of osteopathic medicine, to, Reiki, to, just sitting in a church, in a circle with people and playing the drums, sound baths. Thank you. All this stuff that I thought was maybe foo-foo or it does something, but now I'm seeing that it has a real scientific, I don't want to say physical, but real component to it. There's this great book, I'll bring it up next time, but basically the author was describing like your mind and your body are both made out of matter. Okay? So there's the mind-body connection.
Mine as well.
The mind,
matter.
Yeah, the nerves, the cells, all that. It's matter. The brain, your mind. Yeah. So that in that sense, it's matter, and that the spirit is the thinnest version of matter. Because when you look at the subatomic level, matter feels hard. This book is hard right now, but when you look at the subatomic, they're just a bunch of things vibrating. And they're vibrating and they're stuck together, but on the subatomic level, there's independent things that are vibrating. So if you go to matter and look at the thinnest version of it, that's the way she described it. I thought it was a cool way to think about it. Then that's the spirit. So the spirit is the vibration. The vibration is the subatomic particles vibrating. That vibration exists in humans, in books, in the air, in everywhere. And we have just barely began to describe that vibration. We know string theory and all this stuff is going to take us a long time to figure out, but That's where it's starting to connect. That there are scientific realities that don't connect to our current treatment modalities, and there are spiritual modalities that don't connect, and yet they are connected. And it's becoming quite obvious to me. I wanted to read one more passage. I know I don't know how we're doing on time, but I wanted to read this passage. I'll try to abbreviate it. So Stanislav Grof is describing, it's an analogy of how the consciousness is relative to the mind. So imagine a relationship between a TV set and a television program. The situation here is very clear. Since it involves a system that is human-made and operation is well known, the reception of the television, the quality of the picture and sound depends on the proper functioning of the TV set and on the integrity of its components. Malfunctioning parts coincide with very specific changes in the quality of the image of the program you're watching. Some distortions lead to very specific changes in the color, the sound, and, changes in the TV. Like a neurologist who uses changes in consciousness as a diagnosis tool, right? A television mechanic can interfere with these components of the TV to change the way that television show is being seen, which is what we're doing with manipulating the mind. Since we know the basic principles of TV technology, we don't of consciousness, but we do of TVs. It is obvious for us that the set simply mediates the program and that it does not generate the program. We would laugh at someone who would say or try to scrutinize the transistors and the circuits of the TV or analyze the wires to figure out how the TV created the program. The TV definitely does not create the program. It is a conduit. We pump it in through the airwaves or we plug it in. So that's our brain, our mind is the TV. We, as clinicians, manipulate the mind to change how the person with the brain perceives the show.
Yes.
But the show is not coming from the mind. The show is is everything. It's the energies being pumped in by the universe. It's the energies that are being projected to you in that moment. And of course, it's what's in your mind. It's all of those things. So it's the components of your TV and it's the TV program being pumped in. Some people might think that sounds crazy, but to me, that is the only thing that would make any sense with what we see happening, because I personally do not believe that all of these people we're seeing with depression, anxiety, addiction have some foundational thing that's broken with their brain or broken with their nerves or broken with their hormones. Like people have metabolic disease, people can have psychopathies. Look, we don't even know what causes schizophrenia, you guys. Let's be real. We don't know. We didn't even know that antidepressants aren't doing anything because the serotonin thing was we don't know anything about the brain. I did neuroscience research before I went to medical school. I have 4 publications in neuroscience research trying to understand how our brain learns spaces. Really fascinating stuff. And you know what my takeaway was is we don't know anything about how the brain works.
Right.
And then when you look at the research for antidepressants, it's like these random levels of all of these components on a brain of a rat that was taking the drug that was then killed, sliced, and then stained to look at some components. You don't know what's happening. That's such a brutal, primitive way of trying to understand the brain, So
we know, at least now we know that we don't know. And that, I think that's getting newer, right? Like when it comes to neurobiology, to neuropsychiatry, neuropsychology, we know that there is so much that we don't know. And with that, and going back to thinking about this as the TV set, right? We in psychotherapy, we talk a lot about nurture versus nature, right? So what is the one that defines if someone will be able to cope with trauma? Some people are more resilient than others. A lot of my work when it comes to trauma focuses on post-traumatic growth, PTG, right? Which is somewhat newer term to look at why some people not only are resilient to trauma and cope well, but they actually become more successful and empowered, based on the trauma that they went through. So we don't know why some people are able to cope better than others. We have ideas, but we cannot measure it. We don't know for sure what that is, because we can put two human beings that went through the same trauma, difficult experience, and one of them maybe becomes a therapist or a doctor, right? And then the other one goes into addiction and maybe dies young. So we need more. We need to know more.
What if I tell you that nature versus nurture is also a foundational fallacy?
Right. Like that's what I'm saying.
Doesn't explain anything.
No. And actually, we have come to know that it's both. It can be both.
And consciousness. So there's a great book called The Biology of Faith. And I think it comes to this question of why is faith, evidence-based, showing that people are happier when they have something to believe in, right?
Yes, that is true.
And it's consciousness.
Even if it's not religion.
It's not religion, yeah.
I'm not.
No. Faith is not religion. Religion is one version of belief. And there's a million other beliefs. And there's also like religions that people don't think about as religions that should be, it's not just 3 religions in the world or whatever,
Or philosophical stances like humanistic, right? I mean, humanism is a philosophical stance. So.
And you can believe in the person. So you can believe. And there's been religions that are like, okay. We got to wrap this up. We can keep talking forever. I want to also mention, I think we're going to have to do this on another episode, but we talked about holotropic states of consciousness as it refers to psychedelic medicine. There is a plethora of other modalities. I think I'm going to have another guest on the podcast and have you join us and talk about some of these behaviors. I want to talk about holotropic breathing. I want to talk about ceremonial experiences. I want to talk about cold therapy. I want to talk about fasting. All of these things have a role for your mental health, for your spiritual health, for your connection with other people.
Can we throw in positive thinking?
Always.
And empowerment.
I think your anchoring to that is so important because I'm actually anchored to traditional Western medicine. I think if anyone, why are we different than some of these alternative practitioners or the people that are fully bought into Western medicine? It's because we're anchored in what we're actually doing. We're not pretending that we're just going to go off and only see patients for cash and cut out millions of people from this. No, we're trying to bring it together. And I think that's what it's about. It's about the integration of the conventional modalities with everything else.
And that's, I think that's my goal and my ever-changing goal. It's trying to think outside the box and looking at people as unique individuals that deserve unique treatment, right? Very individualized treatment, which is what we try to bring.
Absolutely. Berenice, thank you so much.
Thank you for having me. This is fun.
This is so fun. We're going to keep doing this. I think, look, me and Berenice work together. We're learning in real time. We're going to share our journey. I think that this was a great start, and we're going to keep learning. We're going to keep helping people, and we're going to share our stories, and we're going to bring in others. This will be, I think, a recurrent kind of thing on the podcast because I think this is what people need to hear, process, and understand. And maybe they need to hear this stuff over and over again. And just like the nutrition, my podcast, 50 episodes on nutrition and people still ask me questions, So I think this is a great start. Thank you so much, Berenice.
Thank you for having me. This is fun, and I could do this for hours.
If people are interested in you, how can they find you?
So my website, www.theartofbeing.net, and my practice is in Woodland Hills, Berenice Rosillo, The Art of Being Psychotherapy.
Thank you so much, Berenice. And until next time, goodbye.